we will get started. So welcome everyone to Dr. Moldwin's live Q&A session as part of the ICA's fall fundraiser, Step Up for IC BPS Awareness and Educational event. We are so excited you are here with us. A few housekeeping items before we start. To ask a general medical question, not personal, please use the raise hand feature in Zoom. You will be asked to unmute yourself. Please stay muted when you're not speaking. You can also ask a question using the Q&A feature. And as a reminder, we are recording this event. And we will answer as many questions as we can in 60 minutes. Next, I would like to introduce Dr. Robert Moldwin. Dr. Moldwin is the professor of urology at the Zucker School of Medicine at Hofstra Northwell. He is also director of the Pelvic Pain Treatment Center at the Arthur Smith Institute for Urology of the Northwell Health System. Dr. Moldwin has a national and international reputation as a leader in the field of pelvic pain with special interest in pain syndromes, including interstitial cystitis, bladder pain syndrome, and chronic prostatitis, chronic pelvic pain syndrome. Dr. Moldwin serves on multiple medical advisory boards, including the ICA, and is a past member of ICA's board of directors. So without further ado, welcome, Dr. Moldwin.
Thanks, Jenny, I really appreciate that. I guess we can just get right on. We'll just get started right off the bat. Any questions? Because I can talk on any. I mean, I'll babble on anything. So if you want to throw some questions at me, things that have concern. The only thing I would ask you to do when you ask a question is, I'm not going to be answering questions that have to do with your specific situation. I mean, I can't hear a list of medicines and this and that, but if you want, basically the kinds of questions where the audience, I think, is going to be generally interested are general questions. So if you have a problem with diet, we can ask a general question about diet, but we can't go into all your specific food sensitivities and all that. It's just not really fair or helpful to the other participants. So again, try to keep it as general as possible. And I think everybody, and hopefully we'll give you some decent suggestions, answers, or comments. And also just keep in mind, there are a lot of ways. Interstitial cystitis, the whole field of pelvic pain is, it's still to a large degree a bit of an art form. Not everybody paints the same way. We generally practice with certain guidelines, but there are factors that we uncover as far as patients in the history and the physical examination, how have you responded to other therapies in the past and all that, that may guide care differently between one clinician and another. So what I will be telling you is sort of the way I do things, not that it's right or wrong. It is just this simple person's approach who's just been treating patients for the past many years.
I have a question.
Sure.
Hi, good morning.
Hi, good morning.
Yeah, I was wondering how you feel about in differentiating between an infection or IC symptoms, how you feel when somebody gets a culture that comes back positive for beta hemolytic strep, because I'm looking at 2 urologists and I just noticed people have different philosophies on it. So I was wondering how you feel about that in general, about that organism.
Beta hemolytic strep is generally a vaginal flora. It's usually not something that would have a negative effect in a bladder unless there would be some, one might expect maybe an immunocompromised state or something like that. But in general, it is not. When we look at any kind of urinalysis, we're looking at to figure out whether somebody has an infection or not. We generally look at two separate things, but two issues that come together very closely. One is the urinalysis and one is the urine culture. The urinalysis is helpful because we're looking for any evidence of contamination. There are certain clues that one might see on a urinalysis to say that this really wasn't this is not a good sample. We're getting, for example, some vaginal contaminants in it, like beta strep. Often we'll see under microscopic examinations a lot of vaginal cells, which again give us an indication that this is not a great sample. The other thing we're looking for are the presence of pus cells, white blood cells, which indicate that there's actually some inflammatory event going on. So one sort of has to always question, there are, this is a debatable topic, but whether really an infection is present when you see, let's say, a positive culture and a completely negative urinalysis. We have to maybe repeat or look into things a little bit more in depth. I'm sure somebody will ask a question at some point in time during the hour about embedded bacteria. How hard should we look for bacteria? And that's really a controversial subject, which touches upon, our concern for our patients and why not try some empiric therapy to see how it goes, and our concerns about over-treating patients and what we call antibiotic stewardship. The bottom line is this, that the closer you look at the urine, you're going to find some bacteria, you'll probably find viruses, fungi, etc. The concern, of course, is that, maybe they're real, maybe they're causing an issue, maybe most often, of course, when they're found in minute quantities, most people would probably say they're it's either a contaminant or it's not a pathogen, meaning something that's going to cause you harm. My own philosophy with this, looking at people who come in with, IC-like symptoms, and they come in with negative cultures, but they bring me, a next generation sequencing test that says they have 5 different types of germs there. I usually I wouldn't push to treat that. I think I'm probably going to end up over medicating patients. And then the concern I have is you start to, of course, as we say, chase our tails. You finish up, then you repeat it. You repeat this analysis, you see more, you treat more, and you can go on. And I don't think we're necessarily doing well by patients. Also, I just should say that there's, everyone is, of course, looking, for that one organism, that one, sort of like in the field of gastric, stomach ulcer disease, the H. pylori. Is there some one organism that is responsible for all this nonsense that you have to experience? And to date, we really haven't. There's no real clear identifiable organism. And believe me, people have looked quite, really hard with it. So on the other hand, do I think that there are some patients who perhaps, have had infections in the past, and perhaps there's still some active infection below the surface? And is it worthwhile to try to give them some empiric courses of antibiotics? I think in certain circumstances, it would be a reasonable thing. But once again, getting back to stewardship, you have to be very careful about saying, listen, you're not responding, to the antibiotics. Enough is enough. And as I'm sure many of you online have seen, a lot of people actually have gone the other direction. They've been treated with tons of courses of antibiotics, and they haven't responded. And lo and behold, the cultures are negative. And that's when the diagnosis of interstitial cystitis bladder pain syndrome that's when the light bulb goes on and say, whoa, maybe something else is going on here.
Okay, I did read some articles from the UK that when people are over the age of 60, that they do treat beta hemolytic strep. So it seems like there's some controversy, in different countries. So I was just curious to your opinion.
I think you have to be very careful. And at the very least, when somebody finds something like that, and you think, I've had patients with something called staph epidermidis and huge colony counts, and they have pus cells. And I actually and that's considered to be also a germ that we normally see just on the skin. It's not considered in general to be harmful, but in certain circumstances, maybe it is. Is it worthwhile to try? Then that's a decision that has to be made between the clinician and the patient. There's no question about it. The other, the other way of doing it is to sometimes you'll see clinicians decide, listen, it seems like it's a vaginal contaminant. Why don't we actually do what's called a straight cath urine specimen instead of just peeing into a cup and analyzing that and trying to do your best on what's called the midstream collection, actually do a catheterization, which is not perfect also, but it's the best we usually can do in the regular clinical setting to get a better fix on whether this is a real, is this really in your bladder or not?
Thank you.
Sure. Hi, Janet. You can unmute. Oh, Janet! Oh my God! I'm gonna
Janet.
Yeah, hi there. Yes, of course. Hi.
I have a question. And you said don't make it about yourself, so I'll make it a general question. Do you believe that when a person has sleep apnea, in which they do wake up, but if they also have, IC, can you tell the difference, or can you?
Yeah. Oh, great question. Okay, so sleep apnea. I mean, I'm not a sleep expert, certainly not with sleep apnea, but I will say that I'm certain that sleep apnea, and this is a well-known concept, sleep apnea can absolutely have an influence on something called nocturia, how many times people wake up at night. I think that interstitial cystitis and sleep apnea together are not a good combination. I mean, it's and sometimes it's hard to dissect the two apart from another in terms of the number of times you avoid. I mean, the only way really to sort of figure it out a little bit, and I personally say throw the book at it. If they've identified sleep apnea, treat the sleep apnea, and of course it gets involved with CPAP machines and things like that, and then see where you stand. You know what I mean? And then it's sort of like peeling the onion. Okay, so if you've really treated the sleep apnea, then you know that clearly is participating in it. And then, of course, you may see exactly after that's treated how much, I mean, maybe it brings you down from going to the bathroom at night 7 times down to 4. And then we may be able to make up the rest of the way with some of the regular medications we treat, IC with, whether it be hydroxyzine or amitriptyline or nortriptyline or any, lots of different agents that we can talk about. So that might also play a role. So I think it's, people waking up at night with who have interstitial cystitis. I think your point is very well taken. You may have other reasons that, affect you separate and apart from the bladder. And unfortunately, I think, again, they sort of synergize a little bit in making you feel even more miserable. They act together. So you do have to treat them as separate issues, independently, and hopefully you'll get a good effect from that kind of multimodal therapy.
Thank you.
All great questions. Really controversial. Love controversy. Love interesting topics. Any other questions? You can just write them down if you're too scared to talk.
Dr. Moldwin, you have the list in front of you too, so if nobody here has questions,
okay.
You can go ahead over to that.
All right, well, so I have like a little list of questions that people have asked sort of ahead of time. So why don't I get into some of those? There's a question about COVID, which I thought was obviously very timely. And in terms of how it might affect the bladder, is there, especially with this long COVID and all that. I personally, in my practice, of course, we see a lot of IC BPS patients in the practice. I haven't really, to be honest with you, I have a lot of patients I think my IC patients probably have a tendency to have lower prevalences of COVID, I think, than the average population, because I think they, as a group, they tend to be more medically conscious and are more wary of putting themselves into a vulnerable position. But the ones who have acquired this wonderful condition seem to be okay. I don't see a heck of a lot of long COVID in my patients, knock wood, and we're doing okay. But if you do look at the literature, you do, and it's funny, I just was looking up some of this stuff last night. You do see there's maybe some correlations. Some centers have seen some correlations with the development of overactivity of the bladder. Haven't seen a heck of a lot with bladder pain per se, but just increased frequency, as some people are seeing. People are looking actually at children and possibly some link to kids who develop COVID and the development of bladder dysfunction. There's a lot of literature on neurological effects, long-term neurological effects. You've heard of chronic fatigue and something called dysautonomia, which affects what's called the autonomic nervous system, the way your bladder works, the way we sweat, our heart rate, things like that. And so we do know it does have, in some instances, it can have these long-term effects. And the question really is, if it affects someone with who has bladder-based pain and irritative symptoms, it probably, at least the way I look at it, is probably going to affect during, by that route, by some influence on the nervous system. One thing that we have seen with COVID patients, particularly those early on who've had really bad pulmonary problems, they're coughing and a lot of upper respiratory issues, just the coughing, the increased, I think a lot of the coughing and the bearing down, which puts a lot of stress on the pelvic floor, aggravates that particular issue. So I think the patients who have a lot of pelvic floor pain, and maybe even voiding symptoms due to pelvic floor dysfunction are probably the most vulnerable to problems with COVID, particularly those forms of COVID where you're doing a lot of coughing, which again puts a lot of stress on your pelvic floor. All right, something again just to keep in mind, and if your symptoms do get worse, at least maybe to speak with your clinicians, or if you're pretty facile with your own pelvic floor, you've seen physical therapy before, and you see symptoms are worsening, maybe time to recheck that specific issue and get some further treatment, whether physical therapy, just the institution of pelvic floor relaxation techniques, avoidance of pushing and straining, again, making sure you're not constipated. Heat application and even muscle relaxants can be helpful in those specific instances. So that's my long dissertation after COVID. There's another question I have here on neuromodulation. So I'll talk about that. And then we'll get into Paxlovid. I see one other. So neuromodulation is I'm just going to make this a very broad question. The specific question is on a specific type of neuromodulation by a company called Exonics. There are two forms of neuromodulation that are often used for interstitial cystitis patients. One is something called PTNS, or posterior tibial nerve stimulation, which is essentially putting a little needle in the area of the inner ankle. What that does is it seems to, and it's electrified, and by stimulating that area where what's called the posterior tibial nerve is, we can actually, strangely enough, have changed the way the bladder operates a little bit. It is approved for overactive bladder and for people who have urgency frequency syndrome. It may even help some patients who are not emptying out their bladders all that well. It is not FDA approved for interstitial cystitis or for pain. I think for IC patients where urgency frequency is their main problem, this is a reasonable way to approach it. But for pain, not really seen great responses, nor do I think there's a lot of literature that's developed which has shown, great success. Again, that's just been our experience. As far as the pain is concerned, other forms of neuromodulation called sacral neuromodulation have been used. And that's a little, ultimately, not to get into the specifics of it, too heavy specifics of it. It ultimately ends with a little device that looks like a bit of like a pacemaker, and rechargeable units even have smaller devices that are underneath the skin. And there's a lead, a very sophisticated lead, a special kind of wire that brings electricity down to the nerves that come out of the sacrum, the very, very lower portion of the back. And it's all hidden, it's underneath the skin. It's put in through an operative approach. It generally involves a test procedure to see if it's actually going to have a benefit, and then a final implant. There are two major companies that that produce these devices. One is Medtronic, the other one is Axonics. They're both very reputable companies. I can't rely. Most practitioners tend to work with one company versus the other, mainly just because of usually they're just their comfort level working with the representatives from either company. But they both may have an impact on pain and on urinary symptoms. I generally reserve these types of devices for people who not only have pain, but also have another clinical indication for it. They're just going to the bathroom very frequently. Really good, I think, for those patients who have what's called persistent urgency. Patients always feel like they need to go to the bathroom. So I think it can have impact with that. Just so you know, the old units of these types of devices, you could not use them. You could not take an MRI, a full body MRI, with one of these devices in place. At least not any. You could, but it has to be just a head MRI. You couldn't take anything below there. And so many of our patients have lower back problems, and they need MRIs for other reasons. That was really a sort of a hard stop for many people. And now, it's been switched around where they're now MRI compatible, which is awesome. The patients are quite happy with it, and that's where we are with that. The other thing is the newer batteries are incredible. I think they're just telling me the new ones can last up to somewhere between 12 and 15 years even. There are rechargeable units, and they both have their pluses and minuses that you can go over with your individual clinicians if you're interested in such a device. But they do have their downsides. They can, rarely they can become infective, and that's a tragedy because then you have to remove the whole thing and hang tight without the unit. It can eventually be replaced, but that's a clear-cut reason for removal. The lead can become displaced, and there are instances where these things need to be reoperated on to get them in a better position. Sometimes they need to be reprogrammed, and usually clinicians who are involved with these devices have personnel in their offices. So you come in and they have all the special monitoring tools to figure out to change the program to give you the best response possible. Have patients tolerated? I have another question here. How have patients tolerated Paxlovid? I think they've been doing the ones that have been, but to be honest with you, I'm talking about a handful. So we're talking about anecdotal, an anecdote from me more than anything else. Paxlovid is just, I had COVID, unfortunately, a few months back, and I was on Paxlovid. It's just not it just gives you a horrible taste in your mouth. It wouldn't surprise me if some of the patients might have it might irritate their bladder a little bit, but I haven't heard any negative feedback apart from the nasty taste that patients derive. One problem with Paxlovid is that you need to come off lots and lots of different medications. So it could be that you might have to stop some, and your doctors will have to, there's a whole long list of medications that cannot be taken with Paxlovid. and it may be one of your IC-related medications. So just on that basis, it might be a tough time for any individual. But it's a 5-day. I think it's a 5-day course of care. I'm sorry, for those of you who don't know what Paxlovid is, it's an additional medication that may shorten the duration and severity of COVID-related illness. Okay, another question. All great questions. Love them. What are your thoughts on the use of Gemtesa? There are 2 medications that are out right now, Gemtesa and Myrbetriq. These are both beta-3 agonists. They're not, theoretically, they're not really IC-related medicines, okay? What they do is they relax the bladder. They're there, and their indications are for overactive bladder. So people who have to rush to the bathroom. Now, the deal is this, that probably about 16–17% of patients afflicted with interstitial cystitis, the bladder pain syndrome, have a little bit of overactive bladder. And people even discuss, is there some kind of crossover between, overactive bladder and interstitial cystitis? Because, especially those patients who are actually leaking urine. They just have to go to the bathroom all the time. So these types of agents are sort of neat because they have the ability to calm your bladder down, but they don't have the negative effects that the classic agents used to treat overactive bladder have. And those are the anticholinergic agents, and their side effects include dry mouth. Sometimes they can affect your mental functioning. Okay, they can make some people a little loopy, and that's why we really try not to give these medicines in the elderly or frail population. They can also cause, and this is the killer one, constipation. So if they cause constipation, I mean, many of you, I'm sure, have had problems with constipation because that constipation does have an effect on bladder function as well. And so, you may help the bladder, but now you're causing another problem. So we're trying to look for other agents. So these agents now don't have, as a general rule, don't have these types of typical properties. Not that they can't, but they usually don't. The only problem we look at in these agents, particularly the Myrbetriq, which is Gemtesa's competitor, they both work by the same mechanism, is a rise in the blood pressure. So we have to be careful about that. But Gemtesa seems to be safe. It seems to be effective. I am using it relatively frequently. And the next question is, well, how much does it cost? And what am I going to say? It's horrible. It's any of these newer agents. It's a coin toss, and not usually in your favor. It's a loaded coin, sort of against you, whether your insurance is going to let you have it or not. But they are helpful. We even, in some instances, will combine a medicine like Gemtesa and an anticholinergic agent, because let's say the Gemtesa, which is generally a relatively mild bladder antispasmodic, it helps, but it doesn't really do the trick. Well, we don't have another medicine, and we can't just keep on doubling and tripling doses. That doesn't work. We may add a low dose, perhaps, of one of the old medicines, the anticholinergics. That way, we don't have to give you a big dose of it. And by spreading it out a little bit, the side effects, it works very well for people. There's another question about hydroxyzine. Hydroxyzine is one of the big 3, I guess. I hate to say the big 3 have been around for a big 30 years, probably, is the major medicines we use, at least initially for IC patients. Hydroxyzine is an antihistamine. The basis for its activity is that we have seen lots of allergies in IC patients. We have seen high levels of histamine, which is something that is produced, which is produced by a cell called the mast cell. And we know that mast cells are found in the bladder, and they tend to release that histamine. So hydroxyzine blocks the release of the histamine, and hence the concept is that people will feel more comfortable after quite a bit of time of taking it. Usually it can take anywhere from 1 to 3 months to really see any clinical effect. Studies on it are really sort of mezza as far as the results. I think that people have used it historically, not just based on the theory behind its effect, but also it does seem to help a lot of people calm their bladder down. It's sort of a little bit of a muscle relaxant. It also helps people sleep at night and sort of augments some of the other medical therapies that we might apply to the IC patient, but it really can help people sleep a bit at night. And so we use it relatively frequently. I often will use it in conjunction with an agent such as amitriptyline or nortriptyline, which is another one of the typical meds that's used for the treatment of ICVPS. Using them together, the concept is we can give you maybe a low dose of one and a low dose of another, and thereby avoid the higher level of adverse events that can occur by giving you one of them, one by itself in a higher dose. So we sort of spread it out a little bit, and it seems to help a lot of people. What type of supplements do you recommend? Water. Let me just say something, because people talk about supplements, they talk about diets and things like that. I don't really, I think there's, I think a lot of people spend a lot of money on supplements. And I think if there's no harm done, I think that's fine. Obviously you'll hear about a lot of different things, from mushroom roots to turmeric to, various things. In general, I don't think there's a problem. I think that in some people, they do really feel that they're having some benefit from it. The problem is that, as a clinician, researcher, scientist, it's hard to push something and tell people to do them without a lot of real, hard science behind it. I just hate to see people go on and on and on working with specific items and spending a lot of money, and ultimately it really wasn't helping. So my best suggestion to people is try a supplement. Try, you can try mushroom root. You can try, all the various things that are out there, turmeric, omega-3 items, and so forth. But sometimes it pays to just stop it. Just like I would often tell people to stop any medication and see if it really is helping. Just don't go on and on and on spending, $100 a month on supplements when you probably could, use the money for other things. So just be careful with it. I mean, the only supplement that there's a little data and that I know of is something like something like quercetin, but even that it is a bioflavonoid. There is some data to suggest that it might help bladder-related symptoms, but that's and I suggest that to patients. And there are all sorts of, most of the supplements that you'll see on the internet, and you'll see you'll see a Q on them. It usually means there's some quercetin in that specific product. I think maintain a really good, healthy diet, perhaps even working with a nutritionist is helpful, and just getting just a little bit into diet. There are no questions about it quite yet, but I would say that, and I just want to make a plug for water. And the reason I do that is because I know you don't want to drink fluids. I know people have a tendency towards, I see patients have a tendency to underdrink, and people get really into the whole diet thing. Probably one of the most important things you can do, no matter what, is if you think you ate something wrong, then I would actually suggest probably maybe diluting it out, just like you would do, anything. You don't want to, if you put too much sugar in your drink or in your coffee, you might add more coffee to it. That's probably a analogy, but a bad statement to make, but whatever. Again, you can dilute things out. When your urine is very concentrated, really what I'm getting to is that many people will actually have worse symptoms. So the tendency, I know you don't want to drink so much that you're going to be urinating all day and all night long, but the best form of management, I think, just as far as diet is concerned, is try to get a little bit more liberal with your fluid intake. It's not, it may mitigate a bit of the pain that you're having based upon any local events that are going on in your bladder. And that's true, I would have to say, for people who have an overactive bladder as well. It's probably, people tend to underdrink. And for those people also who do get that occasional urinary tract infection, there's very good data to show that if we increase our fluid intake on a consistent basis, okay, not just here and there, but really consistently, you can actually have a very marked impact, a marked reduction in the frequency of urinary tract infections, much better than anyone's ever seen with cranberries and with D-mannoses and all the other stuff that you buy. It's as cheap as just keeping a water bottle with you and just keeping yourself well hydrated. All right, let me just take a look if I just don't want to miss questions here. There's a question about Hunter lesions. Okay. Right, so patients with, the question basically is Hunter lesions and tolerating supplements and things like that. I don't, as far as Hunter lesions are concerned, let me just mention something about the broad topic. Patients with Hunter lesions, these areas which are very well defined in the bladder of inflammation, we can actually see them with a cystoscope just in the office setting. And they're not cancers, they're chronic regions of inflammation. We treat these patients a little bit differently than people who don't have these specific lesions. This is a patient group who tend to respond pretty well to local therapies, whether it be putting medicines in the bladder, injecting the actual lesions with steroid, or burning them. We have a little different algorithm of care for those patients, but that does not mean that they don't have, they can't gain benefit by doing these very simple things like dietary changes, like simple medications, as I mentioned earlier on. So we don't hold those back. We don't go straight to doing surgery on those patients. There are lots of other things that can be done, perhaps in conjunction with more aggressive approaches to care. My general observation, although no one's ever studied it, is that most patients with Hunter lesions, and there are tons of exceptions to this, they don't seem to have as many intolerances. Sorry, I'm getting some spam thing here. Hello? Sorry. Wow, spam took over my computer for a second there. They don't seem to have as many food intolerances, and so forth, but that doesn't mean you can't. Lots of people do. I think, again, specifically for people who have these lesions, these are patients who definitely need to keep their fluid intake up. And that's really particularly difficult in this group of patients because their bladder capacities may physically, anatomically be shrunken down just because of the scarring that may occur over many years having this particular condition. But just as important, it's important to keep the water flowing through there, because my impression, and I could be wrong, is that you don't drink, it becomes a vicious cycle. You don't drink, you don't fill your bladder up, the bladder starts to actually shrink even more. You just never give it the ability to get to the size it supposedly wants to be. Also, the direct effect of very concentrated urine that you have when you're not drinking enough, you can just imagine, it's like pouring salt on an open wound. It's going to hurt even more. So you need to increase this type of, you need to increase the fluid intake. As far as supplements are concerned and Hunter lesions, I don't have a lot of, I wish I could have more comments on that, but I don't. I think, again, it's important to have a healthy, balanced diet, assuming, working your way through items that seem to have, that appear to have any negative impact on symptoms. Let's take a look here. These are great questions. Wow, they're just, all right, I see lots of, donate to the ICA. Yes, do that. I'm looking at my chat. Absolutely. Are there any other new treatments available? Well, I don't, it just depends on, we're always looking around for new treatments. And I can tell you that we are looking at, for example, clinical trials using Botox into the base of the bladder. There are a lot of, I can tell you without divulging all the company secrets out there, that there's a lot of interest as far as, industry is concerned. They understand that interstitial cystitis is a condition where we only have 2 FDA-approved therapies available, and we need more. And the problem with the 2 FDA-approved therapies, I don't know if you're aware, but the only 2 that have FDA approval is DMSO, which is a medicine that we instill into the bladder, which usually we're not using, at least these days, as first, at least in our practice, as first line care, because it does tend to irritate the bladder before people could ever expect to see improvement. And the other one is Elmiron, and of course, Elmiron, or pentasen polysulfate sodium, is not something that has, I think most clinicians who work with this a great deal, we're not seeing, incredible effects for patients. If that was the case, I wouldn't be speaking with you today, obviously. And also, of course, some of the litigation that's gone on as far as the ophthalmological issues. So what are we dealing with? We need, we need more therapies. So there are a lot of, industry's been looking at new oral medicines. They're looking at medicines to put into the bladder. Lots of different really innovative therapies that we can look out for the future. But, again, unfortunately, they're not right out there for you right now. I think one thing when you talk about, let me just say one thing about new treatments and interstitial cystitis, and that is that one of the problems, I think, I'm going to critique my own, my own profession. One of the problems that we have with, I think, even our own guidelines is that there's a tendency to, I think, evaluate people, and just like we started this 60-minute conversation this morning, oh, you're not having infections after a while. We're going to stop these antibiotics. You have interstitial cystitis, and we're going to just give you these meds, and we're going to follow this course of action. We looked in your bladder. We don't see a Hunter lesion, but we don't see anything. It looks okay, but we're going to treat you for this BPS, bladder pain syndrome. And maybe you get a little bit better, and but you're not happy. You're still going to the bathroom. You're still having the pain. You're still having the pressure. And that's when you have to start to think, and this speaks to this question about new therapies. Sometimes you don't need new therapies. Sometimes you just have to sort of look back and see, maybe there's some other stuff going on. And all of a sudden you realize, oh, wait a second, you have some bladder problems, but you know what? You also have horrible pelvic floor. You need to see the physical therapist. You need muscle relaxants. You need maybe, even maybe shots into the muscles of your pelvic floor, or maybe some of your pains being derived from a problem with your urethra, or what's called your bladder neck. And, where you can get spasm, and maybe that accounts for some of the poor flow you've been having for many years. So, there's a lot of other stuff that sometimes it pays to look for other pain generators, as we like to call them. And by uncovering those things, looking back, saying maybe we're missing something, we can all of a sudden another door of therapeutic approaches opens up, and you say, wow, cool, great, and you make some further progress. So, all right. Anyhow, I got to take a sip of coffee. This is my liquid today. Sorry. All right. Are there any studies on the use of CBD, THC? Okay, so basic cannabis products. I'm just not aware. I try to keep abreast of the cannabis literature on this topic. Obviously, the problem is that for so many years it has been taboo. It's illegal. Blah blah blah. So you can't really do any kind of major controlled trial. My impression, because we have many patients who have in New York who have gone this route. My impression is that there is a benefit that many people derive. Some people just from the CBD, others do need that THC component, and the benefit that they derive that I've seen most frequently is in the urgency component, maybe that discomfort urgency component as compared to, frank pain. I'm not saying you can't have reduction in pain. I think you certainly can. But if I had to say, I see patients have, and I think one of the cool things about the map, the part that Dr. Clemens, I think, is speaking with the group as well about the whole MAP network. I'm part of that. This is the multidisciplinary approaches to the study of chronic urological pelvic pain. One of the neat things that they've uncovered is the fact that, we always think of interstitial cystitis as a pain condition, but you got to also remember that there's this other component to it, which is the irritative symptom component. I got to go to the bathroom all the time. And people sort of assume it's always motivated by the development of horrible pain. Doesn't always work that way. And what many people really focus on is not so much the pain. In fact, the pain is more of a discomfort. The thing that really messes up their quality of life is the frequency. They have to always go to the bathroom. They can't, they're a teacher, they're in front of their classroom. They can't, they have to step out, and it becomes a real horror. And that's really where their quality of life is impacted. And that's what they sort of track over as far as how well or how poorly they're doing. So I think that, so what I'm saying basically is that medicines, or I will call THC or CBD a medication at this point. Yeah, this type of therapy can be helpful. I wouldn't negate the need to treat that urgency component. So here's an interesting question. I'm not sure. So after cancer or other abnormalities are ruled out, can bladder wall thickening and microscopic hematuria be from IC? That's sort of a more specific question, and that's really gets, so I can only really make a general statement about this without seeing pictures and radiography, CAT scans and all that. But basically, bladder wall thickening is something that is commonly seen in inflammatory disease. It can also be seen in cancers and in other types of disease processes, certain types of autoimmune issues, and so forth. And that's sort of the first thing we think about when there's some kind of what's called a focal thickening. You think of a cancer, and you do have to rule that out. What we're finding in patients who have Hunter lesions, those patients who actually have inflammatory disease in the bladder, they can have thickening of their bladder wall, and significant thickening to a point where there are even inflammatory changes that extend beyond the bladder wall. And right now we have one of our resident doctors working on a project looking at all these radiographic changes that can occur. I think, so yeah, it can be IC, but again, it's always important IC is a condition that is diagnosed on the basis of symptoms, okay? The inflammation is a subpopulation of that patient population where, you see these focal areas. And so I can't really say anything specifically about this participant's situation. You can see blood in the urine with patients who have Hunter lesions also. I always get a biopsy on anybody I see with, if I think they have a Hunter lesion, mainly because I don't necessarily, it can be confused for a certain type of cancer called carcinoma in situ. But getting back to the thickening of the bladder wall that can be seen in certain instances, it may, it just shows you how deep-seated some of these inflammatory events are. And probably when we're burning or we do our little injections, we're doing relatively superficial injections, and it may indicate that we may need to ultimately or find ways to approach the inflammatory processes that are more deep-seated, and maybe people will get longer-lasting relief and symptoms. All right. What are my thoughts about using peridium to treat IC? Peridium's, generally peridium, as many of you know, which is phenazopyridine, is a medication, is a urinary anesthetic. The real reason I do recommend it for people who are having flares. We usually use it in the sort of PRN as needed category. There are rare patients that use it chronically. Again, we try to keep doses low because we don't have any real long-term data on long-term effects, or whether it affects your blood count or what have you. We haven't seen any major issues. We've seen some microcytic anemias develop on rare occasions. Most of the reason that it's sort of dogma to have the patient, it's dogma in urological circles to not give this on a chronic basis is based upon concerns that you're going to mask a urinary tract infection, and you don't want to do that, right? Because then you won't treat it, and then the urinary tract infection will get worse. So that's the real underlying reason we don't give people longer courses of the medicine. But I think that, putting any patient on one of these long-term medications where it's not the classic method to treat is really a decision that has to be made between the clinician and the patient. By the way, I hope you notice I'm using clinician because I include nurse practitioners. These are all people nurse practitioners, people in the field of nursing, physician's assistants, allied, however you want to say it. I'm going to give the plug to stay away from providers. I just can't stand that term. It's not. It's something that was created by insurance companies for some reason to sort of. I don't know. In any event, that's a little pet peeve of mine. Can anemia lead to interstitial cystitis? I have not seen that at all. So that's the answer to that question. I'm not sure in what setting or anything like that, but I haven't encountered that. I mean, a patient with interstitial cystitis can certainly have anemia. If somebody has a great deal of chronic bleeding from Hunter lesions, they could develop anemia. But I think that, but I haven't seen a specific correlation there. Okay, where are we on time? We're just sort of getting close to the end, but I think that let's take a look over here. I see a question about Botox. God, these are really wonderful questions. I missed the Botox question. All right, so let me talk to you about Botox. So Botox, of course, is the botulinum toxin. It's a poison. It's one of the most potent toxins that we know. If you get a real dose of this stuff from botulinum, from the Clostridium that produces this substance, you're going to your whole body will be paralyzed, and not a good that's would basically lead to your demise. When given in tiny doses, it's awesome. Okay, as you know, it's used for wrinkles. Okay, it's used to. It has FDA approval for overactive bladder by giving injections of this medication into the bladder. We use it directly off-label to help spasm of the decreased spasm in patients who have spasming pelvic floor muscles. So it's got a lot of on-label, and people have been using it off-label as well. But what about its role in the bladder? Again, it does not have an FDA approval for the treatment of interstitial cystitis. However, it has been used for people. It has been used, and it has this literature that's developed to show that it may be helpful at decreasing pain and urinary urgency frequency syndromes, problems in the IC population. It's usually delivered, at least in a template that is not the same template of shots that's given in the bladder itself for overactive bladder. It's usually given into the base of the bladder called the trigone. It's sort of, if you have the bladder here and it funnels down and urine comes out the bottom, the shots are usually given to that specific area, which carries most of the nerve fibers that come into the bladder. It happens to be one of the most sensitive areas of the bladder. And those injections are typically given during a cystoscopic examination. It could be done in the office. We don't do those shots in the office. We usually take them into the operating room because it's just really uncomfortable for most IC patients to have that done. But it really can be very helpful for many patients, like I say, on many symptomatic levels. Now, what's the downside? The downside is the exact same downside that we tell our overactive bladder patients about, when they have injections all over the bladder. And that is, there are two potential problems. One is development of a urinary tract infection, which, that's treated. We can deal with that. But more, of course, disconcerting is the potential for causing the patient to go into urinary retention, where they're not passing the urine out sufficiently, and then they might need to catheterize themselves during the course of the days, and this could last for many months. So I think just when my patients hear this, they say, whoa, not for me. But what are the patients who I worry about? Who are the patients I worry about? I worry about the patients who already have a poor flow of urine. It takes them a while to get it started. They see that their flow is not that great. They don't feel that they're emptying well. And those are the specific group of patients who I would be myself a little leery about giving those shots. And in fact, I might just say, I wouldn't do it, for someone in my family. If I had to go and it's on the same level of care, I'd probably, in those instances, think more in terms of some type of neuromodulation. If you're, there's sort of even Steven as far as where we place them in terms of our, going up the list of things to offer for patients. All right, let me see if I can get to one other question, if there are any. I don't think there are any others that are really, we talked about urinary tract infections. Oh, let me just say one thing about urinary tract infections. I think it's a good end to this, because we started out with urinary tract infections, and now let's finish up. Just because you have interstitial cystitis doesn't mean you can't get a urinary tract infection. Lots of people can get them. And when you put the two together, they don't work very well. In some instances, when some of our patients are getting recurring infections, I do think it's a reasonable thing to put a patient, at least temporarily, on some type of prophylaxis, just to side table them and let their bladder settle down for a little while. There are lots of different low-dose forms of anti-infectives that can be used. The classic one you may have seen is nitrofurantoin, which is macrobid. There's methenamine, there's trimethoprim, there's Bactrim, which is a sulfamet. So there are lots of different things, and they do all have their pros and cons, something, again, you can discuss with your clinicians out there. I don't think that if they're just occurring here and there, you can treat them as they come. But if it's really starting to have a real deleterious effect on your baseline symptoms related to the bladder pain, then I think it's time to think about doing something a little more aggressive. The other thing that we typically do for patients who are having problems with recurring infections, but they're not really occurring with enough frequency to warrant really chronic prophylaxis, is to have patients treat themselves. We call it's a self-therapy protocol where they're given a cup. They already have a prescription for the urinalysis and culture to come in, and they're already given an antibiotic to keep at home. So as soon as they feel that something's starting up, they can just pee into the cup, save it in the refrigerator. They're going to ultimately bring that to the lab, but they can then right off the bat start themselves off on a course of therapy, and then they get over to the laboratories, let them process it, and then they'll give our office a call to find out if they're on the right antibiotic. Is it really an infection? Should they just stop the antibiotic or what have you? Again, another protocol that might be helpful for people, but again, a discussion between you and your practitioner.
Okay,
How are we doing, gentlemen? We're okay there?
Yeah, I think that we are at our time right now. So I want to thank you so much for being here with us today, Dr. Moldwin. The session was so informative. If you found this event to be of value, please consider setting up a fundraising page and asking your friends and family to support the ICA's mission. Or you can also make a donation at the event page. So far, we've reached 65% of our goal. So if we can keep that up, we'll be able to reach our 25-day goal by the end of the week. And if you need any assistance setting up your page, you can feel free to contact me, and we put out that information in the chat. So thank you so much for being here. And we were also going to send this out to everybody who is registered. So thank you for being here today. And thanks again, Dr. Moldwin.
My pleasure. I would just want to say one word, just a shout out to the ICA. I've been part of them since I literally walked through the door of my hospital when I was just came out of my residency. I walked into an ICA meeting, which was actually held in my hospital for some crazy reason, and that's where it all started for me. Since my affiliation with the ICA, I got to tell you something. This is the most dedicated, wonderful group of people you can possibly imagine. They are looking out for their constituency every single year. They're out there either marching or web communicating with the senators and the senatorial aides to lobby for NIH funding. They really, really need your support. It's really hard to run this organization. Any organization needs money. They need money. I sort of been on the board so many times. I'm now we're just working on the medical advisory end of things. But I just want to tell you guys, I love you guys, number one. And I hope everybody out there who listens to this really, give, because these are the guys. This is the organization that's going to help you defeat this this nasty condition.
Thank you.
Okay. All right. My plug. Bye-bye. Bye-bye.
Bye.
All right. Bye, Tony. So long.